Can you all hear me? Anda, can you hear?
Yeah, hi, Rafi.
Perfect. Hi, everybody. I'd like to welcome everybody to Pediatric Grand Rounds. We have a bunch of people on Zoom. We have some people here in the room enjoying a great lunch. And I'm going to turn it over to Dr. Sandrine Van Schaik, our Vice Chair for Education, to introduce our speakers for today.
Thank you, Rafi, and welcome everybody. I have no idea whether you can see me or the audience here or what you can see or not see. We continue to be creative. We had planned on an in-person panel, but COVID wins, so we decided to not give everybody the next version of the COVID virus and do the panel over Zoom, although there are some of us here in the audience. Enjoying the lunch, as Dr. Hurst said. So it's an enormous pleasure to introduce this panel, and I'm actually going to introduce the person who put this all together, and then she will introduce everybody else. I think we all know Dr. Kuo quite well. Dr. Anne Kuo is a UCSF professor of pediatrics. She practices at Zuckerberg San Francisco General Hospital and is the department director of health equity and community engagement and co-director of the UCSF Center for Child and Community Health. She's the founding director of the UCSF Plus program, Pediatric Leaders Advancing Health Equity, and holds the Academy of Medical Educators Endowed Chair in Pediatric Education. She's a senior advisor for the UCLA-UCSF ACES Aware Family Resilience Network, where she is focused on the establishment of partner and patient councils. She was the co-director of the California ACES Learning and Quality Improvement Collaborative, and I think that's the work that we're hearing about today. Correct, Anda?
Thank you so much for being flexible. And I was really looking forward to being there in person. But yes, as you said, COVID is still around. So thank you again. And I'm just going to take a moment. I could take probably the entire time introducing everyone who's worked on TRIADS, but I'll introduce the people who are here presenting briefly. So we are here joined with Dr. Alicia Lieberman. She's the Irving Harris Endowed Chair in Infant Mental Health and a professor and director of the Child Trauma Research Program at UCSF's Department of Psychiatry and Behavioral Sciences. And she specializes in infancy, early childhood mental health, and is a senior developer of child-parent psychotherapy, which you'll hear more about in this Grand Rounds. She directs the Early Trauma Treatment Network, a center of the Sampson National Child Traumatic Stress Network, and is just an incredible researcher and colleague, and I'm so glad that you'll have a chance to hear from her more. We're also joined by Andy Krakoff, whose career is focused on the intersection of data and community level action, and he has a consultancy called Hillcrest Advisory, which and works with social sector organizations on the front lines of local change to help them communicate numbers effectively and tell stories with data, which is so important, in order to transform facts into impact. And the bulk of some of Andy's work has been with the Children's California Healthcare Foundation and Lucille Packard Foundation for Children's Health. And so I won't go through all the incredible projects he's been on, but they include things like that a lot of us use, like kids health data, kidsdata.org, and has worked with the state and a variety of other large agencies, including the AARP and World Bank and the Gates Foundation, really taking data storytelling. And he was a prior in journalism and was a researcher and a reporter at U.S. News World Report and the Chronicle for Higher Education. I also just want to thank Sada Ismail and Chris Bradley and Nikki Vu Liba, who are also co-developers of TRIADS and will be with us as well today. I think we can go to the next slide. So we have nothing to disclose. And you can go to the next slide. Okay, so these are objectives. So we are here to describe the foundational elements of sorry, I'm having trouble The foundation elements of child-parent psychotherapy that may be applied in primary care and really in other medical care settings. Describe the triad of adversity, distress, and strengths, and practice using triads to some degree, although it's a little hard in grand rounds, and we have been using it more in a workshop format in some of our longer presentations, but hopefully you'll be able to think through, you know, how do I actually apply this in my own practice? Next slide. So TRIADS is an evidence-informed framework to talk with patients and other team members about ACEs, adverse childhood experiences, and create healing relationships, particularly in primary care, but really this can be used in multiple settings. So as many of you know, I'm a pediatric and adolescent provider at ZSFG, and the majority of the patients I see have experienced adversity. And sometimes, you know, I feel kind of paralyzed when I think about asking about trauma and how I incorporate that into a regular team visit. I don't know, what do I say? How do I respond? And I'm a really visual learner, so I've really appreciated having this image. And this image, we put so much time into every detail, which I so appreciate about the team. But now I have this image branded in my brain, so when I walk into a patient room, it provides me guidance in that moment about adversity, distress, and strengths. So the workflow in my brain is what happened to you, how does that impact you, and what and who helps you. And what we've been doing is really taking Dr. Lieberman and her colleagues' vision of translating her decades of work in child-parent psychotherapy to primary care practice. And we had a great opportunity to do this and bring this to fruition with the California ACEs Learning and Quality Improvement Collaborative. And that was an 18-month learning collaborative, which unfortunately launched right when the pandemic hit. So we had to pivot to being very virtually oriented, but it's to integrate ACE screening and response across 15 clinic organizations in California in diverse settings, serving Medi-Cal patients. And TRIADS really supported our goals in CalQuick by providing an approach and framework to screen in a healing and strengths-based way. And we've been able to disseminate TRIADS across not just CalQuick and the Learning Collaborative of 48 clinics, but also to organizations like the American Academy of Pediatrics and their ACE Learning Collaborative called ESHU, which some of our faculty were involved with, including John Takayama and Dana Long and others. And we've since presented at other national conferences. And what I'd love for you all to hear from is Dr. Lieberman, who will share about her experience and vision that really serves as the foundation of TRIADS. So I'll pass it to you, Alicia. Dr. Lieberman.
Thank you very much, Dr. Kuo. It's a great pleasure to be here. And as you know, one of the most important contributions in the recent decades to public health is the finding that adversity and trauma have a lasting impact on physical and emotional health. TRIADS represents an application to primary care, as Dr. Kuo said, of lessons learned in the mental health treatment of young children and their parents at the UCSF Child Trauma Research Program, where for the past 25 years, we have been developing, testing, and implementing evidence-based treatments and interventions to repair the impact of trauma in the first 5 years of life and restore the healthy development of the child and parents' capacity to protect. The basic principles of our core model, child-parent psychotherapy, those basic principles are now applied across the lifetime, from infancy through adolescence and adulthood. And this is then the basis for TRIAD. Now, the figure that you see here is what we call the child-parent psychotherapy clinical formulation triangle, which we use as an effective shorthand to explain to children and to their parents that what happened to the child and the family has an impact on the presenting symptoms that brought the child to treatment to begin with. On the left hand of the triangle, you see the word experience. This refers to specific events like exposure to child abuse, domestic violence, community violence, death of a loved one, growing up in a household like substance use, intrusive medical procedures, accidental injury, the kinds of things that we screen with ACEs. And these are life circumstances that the ACE studies have shown are much more prevalent than we usually believe. On the right side of the triangle, you see behavior and feelings. And we now know from dozens of studies that early trauma and trauma in childhood in general can derail children's healthy development starting as early as gestation. And children show us the impact of these events through their bodies, their physical health, and the way they feel, they think, and behave. The old belief that young children don't remember the bad things that happened to them, that they don't understand what happened, that they are resilient. Yes, children are resilient, but they need help to be resilient. And those beliefs that children won't be affected, that has been debunked now. And we can no longer continue acting without asking what happened to the child. Trauma affects every domain of child functioning, from biological markers like telomere length, levels of stress hormones, and smaller brain size, to measures of cognition like IQ, school performance like dropouts and expulsion rates, social emotional functioning like emotional dysregulation, aggression, relationships with peers, mental health conditions like depression, anxiety, eating disorders, PTSD, and self-harming behaviors like suicidality and substance use, which, as you know, are a crisis right now for adolescents. These are the conditions that we talk about when we speak with children about their difficulty sleeping, their being angry, they're biting their little brother, they're being expelled from preschool. And we say, your mommy told me, your daddy told me that they were fighting and you saw things that frightened you very much. And now you can't sleep and you are angry, and we are here to help you because we know that you don't like to be angry and you know that you worry a lot. And we want to help you, and your mommy and daddy want to help you. So at the bottom, we see how treatment can help. And we talk about the strengths, the joys, the hopes that are also part of the screening, so that the atmosphere that we want to create is one of acknowledging the reality of the difficult situations, but in an atmosphere of hope and of trust and of conveying that we can use that knowledge to move beyond the sadness, the pain, the fear. The next slide, please. And this approach is informed by the knowledge that the stress and fear are reactions to perceived threat and danger that are present from the beginning of life. The amygdala and the limbic system, which register and transmit signals of threat and danger, are fully formed at birth. Crying, as you know, is the child's first response when transitioning from the warm enclosure of the mother's womb to the outside world, with the change in temperature, the bright lights, the loud noises, and the child's response is, this is overwhelming. The first protective response is one of holding the child, covering the child, lowering the lights, speaking to the child, and that gives the child the message, I'm not going to be left alone with my feeling of being overwhelmed. I'm going to be helped. In situations of trauma, the parent is often overwhelmed by the traumatic event and often is unable to engage in that protective response. And In situations of family violence, the parent becomes the perpetrator, or at least the parent is unable to protect the child from the family danger. And in those situations, the child is in a permanent state of what will happen next. I want to turn to my mommy and daddy, but I don't know whether they will help me or they will hit me. And that chronically aroused HPA system, the hypothalamic pituitary adrenal axis, is neurotoxic when chronically aroused and is implicated in mood disorders such as depression, anxiety, mood swings, and irritability, impairs memory and cognition, and is linked to ACE-associated health conditions from asthma and allergies and eczema to substance use, and as I said, suicidality and depression, which increase the long-term risk of morbidity and early mortality. Next slide, please. And for this reason, we have a conviction that we must routinely screen for trauma. There is one study that is among many studies showing that even in a clinic that is designed, a mental health, this is a family resource mental health clinic in New Haven. This is a study conducted at Yale. Among 3 to 6 year olds that were referred for behavioral problems and mental health problems, before trauma screening, most of them were diagnosed as having behavioral, social, or emotional problems, and only 13% were identified as having been exposed to a traumatic event or an ACE. But after they implemented a trauma screening that we developed at the Child Trauma Research Program, they found out that 48% were exposed to 4 or more traumatic events. And we know from the ACE studies that exposure to 4 or more traumatic events across childhood up to age 18 is associated with all the morbid outcomes. These are 3 to 6 year olds that are already exposed to 5 or more traumatic events in the community. And almost 40% of them had PTSD symptoms that were not being treated because nobody screened for them. And so these children were actually having the wrong treatment. And the kinds of things that happened to them were very real, were physical abuse, witnessing violence, sexual abuse, separation from a primary caregiver, the loss of a loved one. So this really says, if you don't ask, they don't tell. And that is why we need to ask. Next slide, please. So this is what we call speaking the unspeakable, because we are believers, because we witnessed the healing power of emotional truths. And I'll give you an example of a little 5-year-old whose father went to jail after an episode of domestic violence, and his mother, trying to spare him, said to him that his father was working very long hours. And this being a smart little boy said, why doesn't he come home for dinner? And so the mother's answers became increasingly more evasive. The child kept asking increasingly more ingenious questions until he stopped asking. But he stopped eating, he had trouble sleeping, he was easily distracted, he became sad, and he started being aggressive at school. The mother brought him to treatment when he was about to be expelled, and we helped with the triangle. And the child's reaction by saying, you saw your daddy hitting your mommy, you saw the police coming, it was so scary, you didn't know what would happen, and now you miss your daddy, but you are also scared of what happened. And now you are angry and you are sad and your mommy wants to help. And the child's reaction was turned to the mother and said, my cousin told me, why didn't you tell me? You are bad, you are going to jail. And this child was saying to us, I lose trust in what adults tell me because they lie to me. There is something about recognizing what happened to children that John Bowlby, the famous attachment theory developer, said restores integrity to the emotional life of children. And so we have found that speaking the unspeakable restores the developmental momentum. Next slide, please. And we have 5 randomized studies showing this. In this slide, you see the decreases in child trauma symptoms in the child. The green color represents children treated with child-parent psychotherapy, where we say, we know what happened to you. We know how it affected you. We are here to help. The orange color represents treatment as usual in the community, individual treatment, play therapy, good therapy for children that don't have trauma, but that don't make a dent in children that have been exposed to trauma when the trauma is not spoken about, is not recognized and acknowledged. The next slide, please. And it doesn't just change PTSD symptoms. CPP, child-parent psychotherapy, also helps to decrease child behavior problems altogether, not only at the end of treatment, which is what we see on the left, but also at 6 months of follow-up. And there are other randomized studies that go on follow-up for as long as 9 years, showing a continuation of the improvements that occur when one is able to be real with the child and the family and talk about what happened in a supportive manner, and then build on that with protective factors. Next slide, please. It not only, this is a 2-generation intervention. It doesn't just help the child, it helps the mother as well. We see that maternal avoidance of trauma decreases significantly. The orange is the individual therapy for the parent. In the community, that's not a significant decrease. For child-parent psychotherapy, even though we are working with a child and in the relationship, meeting together with the mother and the child, by helping the child, we're also helping the parent. And not only maternal avoidance of the trauma decreases, maternal global symptoms of depression, anxiety, somatization, withdrawal, anger also decreased and continue being lower at follow-up. And so this takes us back to how we included these core principles in the TRIADS model, translated from the mental health setting to the primary care setting, by recognizing with our patients that adversity is a universal human experience, and that it might have a negative effect, but it doesn't necessarily have a negative effect, and that trusting relationships are at the core of getting better. And that is why we are asking, what happened to you? How is it affecting you? It might be related to your asthma, your diabetes, your heart disease. And so we believe that healthcare should adopt a relational health approach that promotes trust in the healthcare team and includes the social and emotional context of the whole person. Thank you very much. Anda, I get back to you.
Okay, great. Thank you, Dr. Lieberman. So, from all this work, we developed this model of core intervention strategies. And so in TRIADS, as we normalize adversity as a universal experience and explain that we ask about ACEs because most people have at least one major adversity in their lives. And that increased stress can impact their physical and emotional health, as we just heard. And then we talk about their distressing feelings and their health conditions and offer clear and simple possible explanations of how adversity might be affecting what is distressing them in the moment. And then, of course, to always bring in hope and highlighting strengths. And the important information we got from our patient community advisory board is that these strengths are really important to talk about maybe even first. And so starting with strengths is a possibility to consider. But highlighting strengths, looking at what helped them and how do they help themselves and how we can become part of the helping team. So as I mentioned, again, this framework has really helped me as an adolescent young adult provider at our county hospital. Let's go to the next slide. And we know that it can be intimidating, and there might be a lot of barriers that might pop up for us when we think about bringing an approach like this into our healthcare system, given how stressed we are and how little time we have to spend with each patient. And I really try and channel Dr. Lieberman and to think about, like, how do we make these moments count? And really it's about, in the context of how we look at our patients, how we use our tone. And I remember distinctly, actually, in the middle of the California ACEs Learning and Quality Improvement Collaborative, when we were talking about triads, using this in my clinic, in my own clinical practice. And one of the patients I remember distinctly was a 17-year-old patient who had really, really struggled with her increasing weight. And every time I saw her, she seemed like she just wanted to crawl inside herself, like just really hunched over, and just, I could tell that she kind of was just withdrawing. And the TRIADS framework really helped me find the words. And so I remember saying something like, you know, we're understanding more and more that things that may have happened to people when they were younger may be impacting how they feel and their health many years later. And so you don't have to share with me, but I'm wondering if you experienced difficult things when you were younger that may be impacting you now. And I ask you this because it can help me know how to best support you. And I almost felt like this palpable relief in the room, and she had tears well up. And sometimes when that happens, I worry that maybe I've just re-traumatized a patient or brought something up that I'm not prepared to handle. But actually, I felt like in this case, I was able to validate her experience. I asked her if she'd be interested in talking with someone more about this, and she nodded, and it really opened, I would say, the conversation and our relationship and our ability to address the some of the underlying things that she was grappling with that were impacting her ability to take on some of the recommendations we were making around her weight. So anyway, it has given me a sense of relief to have a tool like this to bring in with me into my clinical encounters. So if you can go to the next slide, we wanted to give some concrete language because this isn't like a small workshop where we can practice what we might say. And so we wanted to, before we go into showing you some of the videos, we wanted to give you some concrete language. And again, there's no right answer. So you might, as we go through these, and when you think about how do you normalize adversity, for example, you in wherever you are might want to think, you know, what would I say to a patient? And I really welcome any of you who have used language like this or thought about this in your own practice to place what you might say in the chat, and our team members who are monitoring the chat will share that with everybody. So please feel free to share your own ways of bringing this into your practice. So, for example, if we're trying to normalize adversity, sometimes we might say something like, you know, a lot of my patients have had difficult things happen to them. Or how do we explain ACE screening without sounding judgmental? And so something you might say is, sometimes difficult things that have happened to people affect their health, even things like asthma or acne. And I may recommend different treatments that aren't working well because I've not asked about trauma and don't realize that difficult things that happen to you, even if they happened a long time ago, are impacting you today. And how do we place power with the patient and ask permission to ask questions? So a general framework is to normalize and make it optional. So you can say something like, we ask all our patients these questions so that we can provide the best care we can, but you don't have to answer them if you don't want to. This is completely optional. You can go to the next slide. Thank you. And as I mentioned earlier, I think some of us might be hesitant to ask about ACEs and trauma because we don't feel like we have the resources to adequately respond. And again, I like to channel Dr. Lieberman. I also want to shout out Dr. Eddie Mockninger, our colleague in internal medicine, who has the Center to Advance Trauma-Informed Healthcare and was also a big foundational element of TRIADS. So, but anyway, I remind myself that sometimes all that is needed in a response is to validate with empathy, that sometimes we tend to want to fix things, and fixing things the way that we think we might need to fix them is not actually what is needed. So it could be simple, like, that's a lot for you to carry with you. I appreciate you sharing that with me. And that is actually what I said in that encounter with the 17-year-old, is I thanked her for opening that up to me and sharing with me. And what do I say to ask about distress and if it's impacting health without being judgmental? And again, some of us are scared that we'll re-traumatize patients or clients. So to stay curious, and you could say something like, do you think what you've shared with me is related to your headaches or overall health? And then lastly, what is a simple way you might ask about strengths and resilience? And I think this might come more intuitively to a lot of us, but I tend to say something like, what are your superpowers? You clearly have a lot of strengths. Who helps you? So many of you are involved with faculty development, and I really wanted to take the time to have Andy walk us through the website on our TRIADS website. And I just wanted to mention that the genesis of the website were Dr. Lieberman and Dr. Chris Bradley, one of the CalQuick coaches, were working with some of the clinics, especially in the northern region of California. And the healthcare teams were asking them, like, could you demonstrate how you do this in an encounter? And they started role playing. And then these role plays turned into these videos. So Andy, I'll turn it over to you.
Great. Thank you, Dr. Kuo. It has been such a pleasure working on this. I've learned so much, and it's always a challenge to try and take something that we're learning in this style and try and convert it into something that works in a digital environment. And that's indeed what we have been attempting to do here. So I'm going to walk you through this, and the key part of what I'm going to be doing is also showing you a video of one of the scenarios, one of the many scenarios that we've recorded, which I will get to shortly. And so we have the website. You know, toward the end, we can certainly put the URL on here, but so you know it, it's cthc.ucsf.edu/triads. And so on the homepage, we are in essence featuring some of the material that is appears elsewhere on the website. So I won't go too much onto the homepage itself. And it's important to note that throughout the development of this website, which did take us a long time, we spent about probably a year developing this. We developed this using some pedagogical methods for asynchronous web-based learning. It was really important for us to think about how we were going to be presenting this information. So let me walk you through some of the sections of the website. You see them up here at the very top. And I want to walk you through them, and we're going to spend most of our time in the practice triad section. What is triads? In essence, we've already heard a lot about this from Dr. Kuo and Dr. Lieberman, but we go into far greater detail here in the What is Triads page. So we have, for example, a lot of information about adversity. We have some videos, including one from Dr. Lieberman, OBGYN, Dr. Johnson, who's been enormously helpful with us in this initiative, and certainly Dr. Mockninger, as well as Dr. Kuo said. So that's the What is Triads page. We also have an entire section devoted to organizational change. And here it is. This material here is aimed at helping you align your ACEs trauma screenings within your organization. So this could be organizing it in terms of the alignment with organizational leadership, for example. Or it could also be related to health equity, aligning with your organization's health equity values. So there's a lot of information that we provide that we hope will be valuable on that front. As I mentioned, the real heart, I guess, of the website is this practice triads section, where we feature 6 scenarios. And yeah, the ideas for these were developed at Lunch and Learns, where we were sort of asked the question of, can you just show us this? And so these videos became a way of us being able to show this to individuals. So we have in each of these trainings, and we're going to go into more detail about one of these trainings in particular, but in each of these trainings, there are 3 main sections. There's watch and learn, and that's an opportunity to, in essence, watch and learn how you can integrate the TRIADS framework in a clinical encounter via brief videos and example responses to questions about ACE screenings. The 6 scenarios, we created them with input from clinicians and from also the Patient and Community Advisory Board. And we had providers in CalQuick, including the medical assistants, the physicians. They're engaging in these scenarios with patient actors. The scenarios are all unrehearsed and unscripted, and we videotape them in essence. Most, all except one, were via Zoom. The reflection section, you see that as the second bullet here. That's an opportunity to provide a guided self-reflection and a videotape reflective conversation between healthcare team members. And it also features a scenarios with or conversations, I should say, with Dr. Lieberman. She often will begin those by having a conversation that says, how did you think that went? So we have medical assistants participating in these, we have physicians participating in these. We really wanted to provide a range of what was going on and what you're likely to encounter. And then the final section of these scenarios are now you try it. It's a guided opportunity to practice applying triads. That could be individually or in a group setting. The 6 scenarios, and by the way, 3 scenarios are from UCSF pediatric faculty. This first scenario, this is with Dr. Dana Long. The second scenario is with Dr. Kuo. We have then some scenarios that address adults. Of course, ACE screenings in California are also done with adults. We have a scenario with a pregnant woman. We feel that's an important one to address. I'm going to come back to scenario 5. That's with Dr. Eddie Cruz, who is here with us today. And we are very grateful that he participated in this and did a wonderful job. And then we did a scenario with related to asthma and with a father as well. We wanted to get a scenario that also reflects a father participating. So let me show you the scenario. So if you click on any of them, you're basically going to get the same structure of information. And so what I want to do first is I first want to read this to you so you can understand the scenario. And all of these begin this way. So Linda, 35, is bringing her 10-year-old son, Javier, to the doctor with concerns that he is having trouble focusing at school. Linda is initially worried by the ACE questionnaire given to her about her son. The screening makes her wonder if ACEs may be contributing to his lack of focus. Her conversation with a pediatrician makes her realize that there's much that she can do to reduce the negative impact of these adverse events. And also just to, again, give you a little bit more background for the video that I'll be showing momentarily, is we want to share with you what Linda is thinking as the ACE screening is introduced. I want to protect my children and I want them to be safe. I also want my children to feel safe. And I feel tense about revisiting the stressful events in Javier's life. But this is eye-opening. I never thought there could be a connection between our family conflicts and his difficulty concentrating. We have a section about learning objectives, and then we go into the videos. I will come back to this. In all scenarios, I believe in all scenarios, we have 2, in some cases 3 videos. So in this case, we have an initial encounter and then a follow-up visit. And this scenario, along with another one, we do in both English and Spanish. So you see that. This watch and learn section also does include information that provides sort of quotes from the video that we felt are particularly important from the provider that, just like Dr. Kuo expressed in the PowerPoint presentation, can give you some language that you can try out. So we have that. And then there's the reflective practices section. And in this section, we ask you to go through a self-reflection of how you think the videos went, what you think went well, and some other questions. And then we want to offer the opportunity for you to hear and learn from a conversation between Dr. Lieberman and, in this case, Dr. Eddie Cruz Romero. And there are always, we've taped many of these now, mentoring moments. And there's some wonderful pearls of wisdom that Dr. Lieberman is always sharing. And the final section is Now You Try It. So in each of these 6 scenarios, we offer an opportunity for you to try this on your own, or if you're in a setting with others, you can try it with others. So that's the main component of this website. And what I want to do now is I want to give you an opportunity to hear a portion of the scenario that we recorded. So this is the watch and learn, it's the provider response. So let me make this full screen here. And if you can't hear, please do let me know. I think I've got this set up so you can, so let me play it now.
This screener, what it does is it identifies things that could possibly cause some stress on Javier. And this stress is called toxic stress. And what it does is it causes these events, can cause stress hormones in your body to get high. And these stress hormones can affect your health. So your behavior, your health. And so that's why we're asking these questions, because it will help us kind of identify things that could be affecting Javier. And then we can work together to help you, support you better.
Okay. Oh, that's a little scary. I never really thought about that stuff.
No, things happen, and you know, this is why we're here with seeing you today, because we want to help you. What are some of Javier's strengths?
He's a really good boy. I mean, at home, I never have any problems with him at home, really. He helps me take care of the other 2 kids. You know, he's a good brother, and he gets along nicely with the neighbor kids, and he likes to play basketball.
Oh, great.
Yeah, I think he's pretty good.
Yeah, that sounds like I really want to meet him now. Have you mentioned this, that his dad's not around, and is that something that you've talked to him about?
No. Yeah, we just, we're so busy all the time. I have 3, you can imagine. It's picking one up, taking the other one to, basketball, taking the other one to, classes and extracurricular activities. When I get home, I'm so tired. I make them dinner, I put them to sleep, they watch a little TV before, and I just don't have a lot of time to discuss things. But I also thought he's so young. I didn't think he needed to talk about that stuff. But maybe now that he's 10, maybe it's time.
Yeah, I think, it's really important to be able to discuss these things, because children, children also want to share and talk about their feelings. And so I think it's really important to ask him and kind of, ask him and talk to him about it. See what his thoughts are, what his feelings are, because that can really help your relationship with him too, and help him kind of express his emotions.
Yeah, okay. How would you go about asking or bringing up the subject gently?
I would probably say, how has it been for you that daddy hasn't been around?
Okay.
So that would be a simple way to just start the conversation. I think it would be good to just ask him open-ended questions. Just have him kind of tell you what he feels, and you can go from there.
Yeah. Okay.
And
I just want him to be safe. I want him to feel that he can count on me. I want him to feel like he has a family, a full family, even though his dad's not around. So.
And do you, if you don't mind me asking, do you have people support you, family members, friends, in your community?
Oh yeah. My mother comes sometimes to take care of them when I have a lot of extra work, and when she's not available, I count on my neighbor, Alicia, and she has kids too, and they're in the same school, so
Great.
sometimes she's able to take care of them.
Oh, wonderful. That sounds like you have a very good support system. That's really important. Those relationships with friends and family and the community are really important. You know, I think that, you know, if we start building this relationship and making it, improving it with Javier, some of this stress that he may have could improve. And, you know, some of the things that have been shown to help children with this stress response are things like good nutrition, sufficient sleep, spending time in nature, you know, physical activity, you know, the mental health support we were just discussing, and healthy relationships. So I think those all could really help Javier.
Yeah, he has a hard time sleeping actually. He doesn't sleep for very long. He's like up a lot during the night. He goes to the bathroom a lot, and then
Mm,
yeah, he can't go to sleep. He's always wanting to watch TV, and he's the last one to go to sleep. So,
yeah. So it sounds like that's something we could also address.
hmm
And it could be.
I'll stop it there. There's a lot more rich material. And Anda, maybe I'll turn it back over to you now for some Q&A.
Great, thank you. I just love seeing these videos. You'll see like Dr. Dana Long on there on one video. And when I saw this with my colleague at San Francisco General, Dr. Eddie Cruz Romero, I was just like, wow, if I could just sit in each room on the wall and be invisible, I would learn so much from all of you, I'm sure. Because as Andy mentioned, these were not rehearsed. So if you can go to the next slide, Andy. Yeah, we wanted to just take a little time. I know it's really hard in this kind of format to be interactive. And I was thinking, oh, I'm going to be in the room and I'll see people's faces and I'll be able to call on people. But I can't do that. But so if anyone has language they've used, I hope you realize, like, in particular, I enter this very humbly because I am not a mental health specialist, and I've just learned a lot through this whole process and applying it in my own practice. So there's no perfect words from my perspective. So we'd love to learn from all of you and see how you may have implemented aspects of triads, of asking about adversity and inquiring about the impact of adversity and causing distress, and inquiring about strengths in your own practices. And so if you have language you want to share or approaches you want to share, if you could post them in the chat, we'll share as well with the larger group, because I know not everyone can see the chat. And think through like some of the language you might use yourself. And if we had the opportunity, we would actually practice with you. So while people are doing that, I might call on you, Eddie, if you wouldn't mind sharing, like, if you've used triads in your own practice or any reflections you have about the video.
Thank you, Anda. Hello, everyone. So I would say that I think that honestly, before I learned about triads, I was already using that framework. I think that this framework really clearly points out and discusses and includes the type of topics that you want to be addressing during these conversations, these challenging conversations with your patients and their families. And I feel that it's a methodical way of really kind of going through it. And because these conversations can be very, very challenging. In my own experience, I've had like so many patients where some of the things that Dr. Kuo was mentioning about, you know, feeling like you're traumatizing patients again, feeling like you maybe don't have rapport with them, or why would they share that with you? There's so many feelings that come to mind, you know, feeling that maybe you don't have the capacity to treat this or to address this perhaps, or maybe you feel you don't have the resources, and maybe that might be a reason, or even just feeling that you're not proficient enough. So I think that I think one of the slides, and I think Dr. Lieberman put this, that you don't have to be a therapist to do this at all. You're gonna, you're their provider, and you do all this as a team. And, and that's what medicine is about, is working as a team and not feeling like this needs to be on your shoulders to do all of the legwork and trying to help them. You can't solve all of their problems, but what you can do is be there to support them. Be there to support them, be able to provide resources, being able to help them get to a better place. And I think that is the important part of a provider in these situations. In recording these videos, it was really very, it was a wonderful experience, just being able to look at this framework and, and use it in an organized fashion, because I think it does definitely kind of point out the steps you should take and how you should address this. And I think it takes a lot of practice. I don't think any of us here are proficient in this, because all patients are different and they have different experiences and narratives. And so, but I think that this framework helps kind of step one and kind of head in that direction. And as lifelong learners, I think that this is something we can use to get better.
Thank you so much for sharing that. We all know that there's a mental health crisis or ongoing crisis, not like it's new, and providing ourselves with tools to be able to manage these kind of encounters in a healing way in our own practice, whatever practice we have, I think is important. And I want to thank Catherine Whistler for sharing how she asked about strengths. I just wanted to celebrate that you made it to clinic today. You and your family have survived so much. What keeps you going? And or asking, you're working so hard to care for your child. How do you care for yourself? And another question, who are the people in your community you go to for support? Those are all great ways of asking about strengths. Thank you so much for sharing. And again, if anyone else would like to share, please post them. There was another question about whether we're screening for ACEs and what kind of training people go through. And I just wanted to highlight, many of us are engaged with ACEs Aware, the statewide initiative from the Surgeon General's office, and the UCLA UCSF partnership that some of you may recognize. Dr. Shannon Tyne and Dr. Eddie Mochtinger are the principal investigators on. But they are having training. So on ACEs Aware, there's a training that many of you probably know about, Becoming ACEs Aware, it's called, and you can get go through the training and get certified. Not certified is not the right word. What's the right word? Anyway, where then when you get by completing that training, you can then bill for the ACEs screening. And then also there's a webinar series called Implementation with Intention that we've been doing. And Chris, I don't know if you want to mention anything about that.
Sure. Yeah, we have this awesome new webinar series we're doing with ACEs Aware, Implementation with Intention, like Anda said. We're doing it the fourth Thursday of every month from 12 to 1. There's also something on the ACEs Aware website that shows it. We can maybe try to find the website and put it up for y'all. We did the first one in January. We're doing the second one next month, and we're talking about how to get buy-in and build your team. So that's the topic for next month or for next week, actually, for this month. So we'd love to have y'all get there. You can register for it on the ACEs Aware website.
Great, thank you.
Mm-hmm.
We have another question from Mimi saying she's specifically asking about staff. Do you clinics require staff to be trained in trauma-informed care?
Anyone want to take that question? I think I may have missed what it was, but do we require people to get trained?
Do clinics require staff to be trained in trauma-informed care?
Oh, that would be nice.
Right? I think it depends on the clinic, right? I mean, I know some clinics, when they want to get reimbursed for the Medi-Cal, the $29 for the ACEs Aware, for the ACEs and the Pearl screening, then the providers do need to be trained. other folks can get trained too. It's an amazing training. You can get CE credits for it as well. But as far as each, clinic, I don't think there's like a statewide thing. We'd love that if folks, were required to get training in trauma-informed care, but I don't think that that's a requirement right now.
And Mimi, to your question, I think you're specifically asking like about staff. And so in CalQuick, perhaps you're talking about the like 48 clinics in the Learning Collaborative. And it wasn't required that the staff of all the clinics be trained. I think we allowed each clinic to take their own approach in some ways, but the staff, it was definitely found in the evaluation that it was really important for the entire staff to be engaged and trained and be part of the process of implementing ACEs screening and response. And I don't know, Chris, if you want to speak any more to that.
I mean, when we do learning collaboratives, we have definitely, required folks to take the trainings right before they join the learning collaborative, just to get like the information on the ACEs science and things like that. That's all really important. But again, I think it depends on what your clinic wants to do and, kind of what's important for you. But really the first thing that we kind of ask folks to do when they go on this journey is to take the training, because there's some really great foundational information. And when you have, all folks in your clinic, or at least folks that are going to be involved in the screening process, take the same training, you're kind of level setting. So, kind of you're all starting from the same place. So it is one of the things that, is definitely recommended, but it's certainly, not required as far as, unless you really want to get the reimbursement, which for some folks is really important. And for some folks, not as much. So depends on the priorities of the clinic, I would say.
And Sandrine, you said there's a question.
Hi, it's Mindy Jew.
Hi, Mindy.
Hi, Anda. This is amazing work, and I have a comment and a question. My comment, for people who don't know me, I work in the inpatient setting in the pediatric ICU at Mission Bay, and I'm working with my colleague April Edwell, and we are implementing or have implemented these anti-racist de-escalation simulations in an interprofessional hospital-based setting. So if anyone's interested in it, reach out to me. And a lot of what you're presenting with the triads resonates with me, and how we are approaching our patients who are in distress, our parents who are in distress, understandably, in the hospital setting. And so I just want to make a comment of that I think there's would love to collaborate or talk more. And I sent you an email already on to see how this can be translated to the inpatient setting. And then the question is, has there been work or studies or research on how this can translate to the inpatient setting? Because, you do all this great work as the outpatient docs, and then a traumatic event happens, they're in a hospital, and we know no context about that. We haven't built those relationships. And so what can we do to better put all your hard work and continue that in this really traumatic experience for our families?
Thanks so much, Mindy. It seems like our team should meet with your team and have an additional conversation about how to extend triads and a lot of the child parent psychotherapy premises to the inpatient setting. I know we have like a minute left, so I was just going to quickly see, Dr. Lieben, if you had anything you wanted to say to Mindy. Dr. Jew? Yeah, probably a follow-up conversation. You're muted too, Dr. Lieberman.
Just so happy to be in this setting, building bridges between this approach and primary care, where patients trust you the most. So it's great to be here. Thank you.
Yeah. And I just find it's not like an hour-long conversation. It's more like the approach shifted for me. So it's just a different approach, doesn't necessarily take more time per se. And I know that's not exactly what you're saying, Mindy, but I'd love to talk to you more. So we just have one last slide. If you can go to the next slide, Andy. Just to remind ourselves, I love the quote that Eddie mentioned that was on an earlier slide, and that Dr. Lieberman always says is you don't have to be a therapist to be therapeutic. And we can be our best selves. We can't be our best selves if we're burnt out and don't show compassion for ourselves. So at the end of the day, just remember to take care of yourselves as well. And as Maya Angelou says, if people won't remember what you said or did, they'll remember how you made them feel. And this is really the aim for TRIADS, is to be a tool that we can bring, that you can bring with you into a clinical encounter and support healing. And ideally that would be in any clinical encounter. Thank you for everyone's time and for allowing us to be virtual.
Thank you very much, Anda. We would really want to thank everybody for being here with us. And it was great actually to get everybody's different perspectives. So even though you're virtually on the screen, it was really nice to sort of feel that we could get everybody included in this. So thank you again. And for everybody on Zoom and everybody in the room, we'll see you with next week's Grand Rounds. Thanks again.
Thank you. And thanks, Mimi, for posting about Project Avery. We'll have to learn more about that.